So the subject of today is WHONET and SaTScan for the detection of clusters or outbreaks. SaTScan is a free statistical software made by Martin Kulldorff. He did that here in Boston with the Brigham and Women's Hospital, and also with Harvard Pilgrim Healthcare and the New York City Health Department. The purpose of SaTScan is not specifically to find outbreaks, it's to find case clusters. The case clusters might be an outbreak, but there might be other issues such as contamination. Therefore, during this call, I will go back and forth between the word cluster and the word outbreak. We are often looking for outbreaks, but there can be other explanations for case clusters. Next slide. So the WHONET webinar series. You can find the videos for the past webinars on the WHONET homepage if you click on webinars. The audio is available in English. The subtitles are available in approximately 20 languages. These are the topics that we have had so far: WHONET and WHO GLASS, WHONET macros and reports, WHONET and multidrug resistance, multidrug resistance profiles. The subject of today's webinar is WHONET-SaTScan and cluster or outbreak detection, part 1. It's an important large topic, so we may have 2 or 3 or more sessions about the WHONET-SaTScan features so that you have a good understanding. These are some ideas about future webinars. In February, the topic might be part 2. We haven't decided yet. This is also a good time of year to be discussing annual antibiograms for hospital purposes or for national reporting purposes. And that will be based on recommendations from the CLSI M39 document. So far, all of our webinars have been on the last Wednesday of the month. That will not always be possible, but in general, we will try to keep with the last Wednesday of the month. We do welcome your ideas for future webinars. Next slide. So today we will talk about possible approaches to the detection of hospital outbreaks. We will start with WHONET and data preparation, followed by a WHONET demonstration of cluster detection using the default settings. We will accompany this by an interpretation of results. Then we will look at the analysis options that we offer within the WHONET-SaTScan integrated package. And finally, I will show a few examples from the literature. This is part of today for part 1. In part 2, we will talk about some of the more advanced features. I can go into further detail about these examples from the literature to discuss the advantages and disadvantages and strengths of the different algorithms that I will discuss. So the focus of today is especially about the mechanics so that you know how you can use WHONET-SaTScan for detecting clusters and how do you interpret the results. So first part, new slide. Approaches to outbreak detection. So Dr. O'Brien had this vision that human health, animal health, food and environmental microbiology laboratories worldwide generate a detailed window into evolving microbial populations in real time. Yet this resource remains largely untapped and underutilized to support policy development and resistance containment initiatives. The use of a common software could and should support local, national, regional, and global collaboration and analyses to support many objectives. Many people use WHONET for antibiogram preparation and national annual reporting and reporting to WHO GLASS. And of course, these are important uses of the data. However, there are additional features of greater value in real time to find outbreaks, to find new threats, to find laboratory quality issues. So the focus of today's webinar is the recognition, tracking, and containment of emerging threats in real time, including outbreak detection. So I will talk about 3 strategies for outbreak detection. New slide. I will talk about 3 strategies for outbreak detection: anecdotal, regular manual review of laboratory data. That could be weekly review or monthly review. And finally, statistical algorithms. I will talk about a simple rule for finding clusters and the strengths and especially the weaknesses of the simple rules. And then I will continue with the more advanced algorithms with statistical thresholds with a focus on the SaTScan features. Anecdotal detection simply means that somebody notices. They think there are more cases than usual. This can be in the hospital setting, it can be in the community setting. So the initial detection of the outbreak often does not rely on algorithms. It's just somebody paying attention and say, you know, I think that we have more than we usually do. For example, ground beef producers having an issue with E. coli in a food outbreak, or puppies and drug-resistant infections. Here, you do not need a statistical software or regular collection of data. You just need somebody to pay close attention. The problem, however, is that it's very difficult. Nobody knows all of the numbers in their head. There's no systematic baseline. You might think there's an outbreak, but you're not sure if there's an outbreak. So anecdotal outbreak detection is very incomplete and can miss important outbreaks. This is an example of anecdotal outbreak detection in a single hospital. The hospital infection control team noticed that there were more cases of Acinetobacter baumannii than usual, but they were not certain. So they asked for a display of recent data on Acinetobacter baumannii to help them in their assessment of whether there was an outbreak or not. What you see is a distribution of the number of people with Acinetobacter baumannii on a monthly basis. In most months, there are somewhere between 1 and 5 people with Acinetobacter baumannii. And then in the first red bars, you see a very large peak, 13 people in 1 month, followed by 9 people in 1 month. And then there was a return of this true outbreak a few months later with 10 people in 1 month. So when the infection control people noticed more Acinetobacter, they were not certain if there was an issue. But retrospectively, it was possible to do this graph and say, yes, there is clearly an issue here. This was a very important large outbreak, which made it easier to detect. But you can imagine smaller outbreaks might also be obvious from the data. However, nobody is going to notice. It's also possible to take this graph with Acinetobacter baumannii and apply a filter. The suspected outbreak was Acinetobacter baumannii non-susceptible to many antibiotics. You see here that this is a graph for Acinetobacter baumannii resistant or intermediate to 7 antibiotics. As you can see, most Acinetobacter are not this resistant. There was 1 or 0 a month for several months in the first time period. And then during the outbreak period, there were 11 people with this multi-resistant Acinetobacter baumannii, followed by 4 people in the next month. So by using the resistance pattern, the graph became much cleaner. We'll come back to this point many times later in this presentation, but resistance profiles can improve the sensitivity, specificity, and timeliness of outbreak detection. We are improving the sensitivity because the graph only includes Acinetobacter with a particular phenotype. We are improving the specificity by removing a lot of Acinetobacter from the baseline that have a different phenotype. And by cleaning up the baseline, improving the sensitivity, we can improve the timeliness of outbreak detection. This is another example of what is possible with routine data review. These are monthly data of Staphylococcus aureus in a hospital, where simply we are presenting the number of patients with Staphylococcus aureus with different resistance profiles. In the top left, you see a graph of Staphylococcus aureus that are fully susceptible to all of the antibiotics that I requested. So these are examples of MSSA, methicillin susceptible Staphylococcus aureus. And you see that it does vary over time. It goes up, it goes down. Over time, the general trend is for MSSA of this type to decrease. In the top right, you see also MSSA. These are oxacillin susceptible. These are methicillin susceptible. But you see they are resistant or intermediate to 3 drugs, clindamycin, erythromycin, and tetracycline. So yes, they are MSSA, but they are a certain kind of MSSA. And as you can see, most of the data do not look like an outbreak. You know, the numbers vary between 0 and 3 isolates per month, except in the beginning of the time period. In 2012, there was a month with 5 people in 1 month. So if you look at these kinds of graphs on a monthly basis, you might notice this kind of outbreak, potential outbreak. In the lower left, we see MRSA that are resistant to only 1 drug, oxacillin, and of course penicillin. And you can see, generally speaking, that over time, these relatively susceptible MRSA seem to be decreasing over time. In the beginning, you see a very large peak with 10 people with MRSA in this time period, and that looks like a potential outbreak. Is this an outbreak? I do not know, but I think it might be an outbreak, therefore it merits further investigation. Maybe there's a contamination issue, maybe there's a quality issue, maybe they are simply doing more MRSA screening. If you do more MRSA screening, that does not mean that there is more disease, but you might find more colonized people simply because you are doing more screening. So on the basis of this monthly review, I might want to look at this. Why do we have 10 people in this month with MRSA? What are their risk factors? Were they screening isolates? Were they in the same location? Were these hospital infections? In the lower right, you also see MRSA, but these are multi-drug resistant MRSA, resistant or intermediate to 5 drugs. And here there's not an obvious outbreak, except at the beginning, there is a month with 4 people in the same month. In the most recent time period, there are 3 people in the same month. Is that random variation? Is this a potential outbreak? I do not know, but I would like to be notified so that I can do a quick assessment to decide whether or not I would like to investigate further. New slide. There are also some simple statistical methods for detecting outbreaks. Unfortunately, these are generally too simple. There is a common rule that many hospitals use to say that if you have 3 new patients with MRSA in a hospital ward in a 2-week period, then this should trigger outbreak mode. This should trigger isolation procedures, investigations. It's a very simple rule, easy to apply. 3 new people with MRSA in 1 location in 2 weeks. Let's treat this as a potential outbreak. However, this rule was created over 30 years ago. It does not consider the size of the ward. It does not consider the baseline incidence and prevalence of MRSA. And it does not recognize that MRSA are not homogeneous. Some MRSA are relatively susceptible, and some MRSA are relatively resistant. So this is an example of a simple statistical rule that many hospitals utilize, but it is too simple. Also, there is a very narrow focus. You only look at MRSA or VRE, and any other potential cause of an outbreak is ignored, including MSSA. People look at rigid time intervals. You look at daily totals or weekly totals or monthly totals. The problem is sometimes if you look at very short periods like a daily total, you'll miss a slower outbreak. On the other hand, if you only look at monthly totals, you might miss a short outbreak involving only 2 or 3 days. They are also looking at rigid geographic units. You might look at ward statistics, or facility statistics, or district or province statistics. The problem is if you look too small, you might miss a broader outbreak. Or if you look at too high a level, you might miss a small outbreak. For example, if there is an outbreak of MRSA in the neonatal intensive care unit, I do not want to be looking at the MRSA totals for the full hospital. I will not be able to find the outbreak in the very small unit. Another disadvantage of these statistical methods is they often have low sensitivity, low specificity, and a low positive predictive value. So many of these can find true outbreaks, but they also often have too many false positives. And if you have too many false positives, then people will stop paying attention to the positive alerts. Also, if you look at all units and all organisms and all resistance patterns, you can have a problem of too many comparisons with too many false positives. There's no inbuilt strategy for adjustments for multiple comparisons. In WHONET, we offer many algorithms and parameter options for finding possible outbreaks. Some of these in WHONET are time trend analysis, looking only at time. This is the traditional approach used around the world for detecting clusters, looking at time only. WHONET also has an option for spatial trend analysis. Are there certain locations that have more outbreaks than you would expect, or more resistance than you usually expect? So this is purely spatial. It does not involve time. It is not looking specifically for outbreaks, but it is looking for concentrations of clusters. For example, it is not a surprise that there is more resistance in the intensive care unit. It's not a surprise that there is more resistance in university hospitals. However, sometimes you have a lot of resistance in a community hospital, and that is unexpected, and that might trigger the need for an investigation. Are they using more antibiotics than other lab hospitals? Do they have poor hygiene issues? Most of the time today, we will talk about space and time trend analysis. I have highlighted in red the three algorithms that we have used for most of our publications. Our early publications, we utilized space-time permutation. More recently, we have switched over to space-time uniform. And we have also done some nice work with spatial multinomial. Many years ago, we also did one publication with QSUM and VRE. QSUM is short for cumulative sums. The CDC has a series of algorithms called EARS, Early Aberration Reporting System. So cumulative sums are the basis of the CDC algorithms for community outbreaks. Many years ago, we also did one publication on exponential weighted moving averages. So yes, we have done these in the past, but we have found them to be less flexible, less rich, less powerful than the options that we have implemented with WHONET and SaTScan. Next slide. So we rely a lot on SaTScan and our collaboration over many years with Martin Koldorf, the biostatistician who developed the free software. You will notice that there is a capital S, a capital T, and a capital S. This is for space and time scan analysis. He made this software and these algorithms initially back in the 1990s, when people traditionally look for outbreaks purely by looking at the time distribution. What he brought in a novel way is the effective use of geography, looking at kilometers, looking at boundaries. The idea being that sometimes if you look, as I mentioned, if you look too small, you will miss a larger outbreak. But if you look too large, you will miss a smaller outbreak. Initially, he did not use time. He only utilized space to ask whether there were certain areas of the United States where there was more cancer than you would expect. So with cancer, The time element was not the most important aspect. Cancer takes a long time to develop, to diagnose, to track, but it's still important that he was able to find certain areas that had more cancer than you would expect and other areas that had less cancer than you would expect. So his primary initial contribution was to look at geography in a meaningful way. You see that image in the top left. Look, and SaTScan has 3 circles there. He is looking at small and medium and large circles all simultaneously. The software is scanning small and large geographic areas at the same time. In the top right, you see a set of vertical circles. This represents to the time dimension. So if I'm looking for an outbreak, many people will look at weekly data, or they will look at monthly data. SaTScan is more flexible. It is looking for clusters using a window of 1 day and 3 days and 7 days and 30 days, all at the same time. So it is scanning on the left in different geographic windows and on the right in different time windows. This allows you to find short outbreaks and long outbreaks with one set of algorithms. So some of the SaTScan features that we like is that there are advanced statistical algorithms for estimating p-values based on Monte Carlo simulations. So it's a fancy approach for estimating statistical significance. As most of you know, Monte Carlo is a city in Monaco, famous for gambling, famous for cards, and famous for probability. An advantage of the non-parametric approach is it does not make assumptions about the underlying data. Many algorithms for cluster detection assume that there is a normal distribution. There is a normal baseline, a normal variation. We might look at 2 or 3 standard deviations above or below the average value, and those do work, but they assume that the data are randomly, normally distributed, and often that is not the case. So SaTScan utilizes Monte Carlo simulations in a way that has fewer assumptions. I mentioned scanning windows in time and scanning windows in space. As an example of a scanning window in time, there might be an important outbreak over a weekend. Maybe 5 people will have a certain disease on Friday. 5 people will have a certain disease on Saturday, and 5 people will have that same disease on Sunday. But if you look only at weekly data, the first 5 people end up in 1 week, and the second 5 people end up in a different week. So instead of seeing this as 10 people in 2 days, we see it as 10 people spread over 2 weeks. So by scanning, SaTScan can look at the 1 day and the 2 days to recognize that these 10 people came from a 2-day period. That is scanning in time. We are also scanning in space. For example, I live in the state of Massachusetts, which is next to the state of New York. If I had 20 people in Massachusetts on the border and 20 people in New York on the border, it is not helpful for me to look at Massachusetts statistics and New York statistics because the numbers will disappear in the much larger numbers for the full state. But because they're at the border, if you have a scanning window with miles or kilometers, SaTScan has the ability to recognize that these people are all closely related. This is what we refer to as a border issue. Some cases are in one time frame, some are in a different time frame. Some are in one geographic window, some are in a different geographic window. And because SaTScan is scanning, it can see these things at those borders. There is automatic control for multiple comparisons, at least when you run a single analysis. So this helps to control against too many false positives. SaTScan was originally developed for true geographic space, using latitudes and longitudes, miles, kilometers. But over time, SaTScan has incorporated new features to look at non-parametric space. For example, these 4 wards are close to each other. I don't want to say how many feet apart they are, but they are related to each other, for example, on the 5th floor. Or hospital groupings. With hospital groupings, 2 miles is a very large distance inside of a city. And in Boston, we have several hospitals within 2 miles of each other. But out in the community, 2 miles in a remote area, 2 miles is not very far. So that's why even for hospitals where we could use latitude and longitude, we often find by grouping them together makes more sense. We group them by patient transfer patterns. These hospitals belong to the same network. These hospitals are relatively close, but we don't have to say how many miles or how many kilometers. SaTScan also permits sort of conceptual space, and resistance profiles is an example that we will talk about later. Next slide. These are some examples of WHONET with SaTScan, and you can see the statistically significant area is highlighted in red. So top left, we see an example of Klebsiella pneumonia with daily statistics, where at the right, you see that there are more red cases than in the rest of the month in a statistically significant way. In the top right, you see Staphylococcus aureus in cardiology. Again, there is a cluster in the January 18th, January 19th. By resistance profile in the lower left, and in the lower right, using true latitude and longitude, where we were looking at the latitude and longitude of specific hospitals in a network. The three slides here, the three graphs here appearing in white, we will see those today during the WHONET presentation, the demonstration. At the bottom, you can see you can also combine these together. For example, I would like to look at resistance patterns by ward and by resistance profile. If you have 5 patients with Klebsiella pneumonia with the same resistance pattern in the hospital, that's interesting. If they are in the same room, that's even more interesting. So we can use SaTScan with a single analysis variable, such as organism or ward or resistance profile, or we can combine them together with 2 variables, and we'll talk about that later. So now we'll talk about WHONET and data preparation. So you would like to choose a subset of isolates in which you want to look for possible outbreaks. For example, I might want to simply choose isolates of Klebsiella pneumonia. Today, I will talk about simple data preparation in a single step. For patients with multiple isolates of the same species, we would like to remove repeat isolates from the same patient, and I will discuss this further on the next slide. There are also more advanced steps that are possible, and I will cover those in a future webinar. For the detection of outbreaks of hospital-acquired infections, it is helpful to exclude the community isolates. For example, you can filter on inpatient isolates only. This is not ideal because many inpatients, in fact, do not have a hospital infection. Many inpatients have community infections requiring hospitalization. So yes, you can remove the community samples and only focus on the inpatient samples, but many of the inpatient samples represent community disease. A better way is to look at the hospital admission day. If a patient has Escherichia coli on hospital day 1, it's probably a community E. coli. If you look at Escherichia coli on hospital day 2, it's also probably a community infection. If you look on hospital day 10, these Escherichia coli are probably hospital acquired. The CDC used to use a definition that for strains found on hospital day 3 or later, they would consider them to be hospital acquired as a simple proxy definition. It is not exact. So the CDC had a definition that strains collected on hospital day 3 and later would be considered hospital acquisition. The CDC later changed that to hospital day 4 and later. So for statistical purposes, the CDC uses strains on hospital day 4 and later as hospital acquired, and strains from hospital days 1, 2, or 3 as community acquired. However, the WHO and other organizations stayed with the original recommendation for hospital day 3 and later. This is not a perfect definition, but it is a helpful definition to try to remove many of the community infections from the algorithms. Another way to do filtering is to look for priority microbial subpopulations. For example, instead of looking for outbreaks for Staphylococcus aureus in general, we could look for outbreaks specifically in MRSA. Or instead of looking at all Escherichia coli, we could focus specifically on imipenem-resistant Escherichia coli. You can decide whether or not you would like to include or exclude screening isolates. The advantage of including screening isolates is that in a true outbreak, not everybody gets disease. Some people will be colonized with MRSA, but they will not manifest disease. So it is appropriate to include the screening isolates as part of your investigation for an outbreak. There's also a disadvantage to screening isolates if the practices for screening isolates changes. At the beginning of the year, maybe there is infrequent MRSA screening. And then later there's maybe a change in policy where they now screen everybody. Or if there's a suspicion of an outbreak, people will start doing more MRSA screening. More MRSA screening will find more cases of MRSA colonization, but that does not mean that it is at a rate higher than the baseline. Also, some places only do screening on 1 day a week, for example, Monday. So you might find these strange quote-unquote outbreaks simply every Monday they're doing screening. So I don't have a strong decision whether or not to include or exclude screening. There is value, but you also have to be aware of your MRSA screening practices. Filtering needs to be accomplished as a series of steps to produce a smaller WHONET file for analysis. So you do step 1, find first isolate per patient. Step 2, let's look at the first isolates on hospital day 3 and later, etc. So I will talk more about more advanced data preparation in part 2 of this webinar. So today I will focus on simple removal of repeat isolates. If you have 5 isolates from the same patient, that does not represent an outbreak. It represents a sick person. So SaTScan does not know if the results come from one person or from multiple people. So before we give the data to SaTScan, we need to remove the repeat isolates to avoid false cluster detection because we did not remove the repeats. How should we remove the repeat isolates from a patient? There are a number of possible ways that we have utilized. And there are other ways. I'm giving you an example of what we have done, but there are other approaches. For example, first isolate per patient per species per year. Or you could do that per 2 years, or you could do it for 5 years. But we have done first isolate per patient per species per year. In this case, we are not looking at the resistance pattern. So this approach is especially useful for organisms that are not routinely susceptibility tested. Fungi, Clostridioides difficile, other anaerobes. We take the patient's first isolate per year per species. So if a patient had MRSA 3 months ago, I want that first isolate from 3 months ago, and I will ignore the MRSA from today because I presume it's still the same episode of infection or colonization. But if the patient had MRSA 5 years ago, I will focus on the current one because it might be a new episode, it might be a new strain of MRSA. The second approach is first isolate with antibiotic results per patient per species per year. This is what we do for most of the bacteria. This is especially useful for organisms that are routinely susceptibility tested. Maybe the patient had Pseudomonas aeruginosa 3 years ago. I don't care about that one. If the patient had Pseudomonas aeruginosa last month, I do care about that one, and I take the first one within the previous year. You can also look at the first isolate with certain resistance results per patient per species per year. For example, you can focus on one antibiotic. choose the patient's first MRSA, choose the patient's first CRE, or you can look at many antibiotics. You can look at Escherichia coli resistant to 3 drugs. In our publications, we have chosen these first 2 bullet points. We are also supporting a project in Japan led by the National Institute of Infectious Diseases, and they are taking the 3rd approach, and I'm very involved in this protocol. The 1 per patient options. You can see in the top left, I can do 1 per patient by isolate, meaning I am not excluding anything. I'm choosing all isolates, or by patient. For example, I want the patient's first Klebsiella ever, or by time interval, or resistant phenotype. And we have always utilized that for our publications. Utilize the time interval and or the resistant phenotype. You then see those 2 options, first isolate only, not considering the antibiotic results. And the second, first isolate only with antibiotic results. So if they have an Escherichia coli that was not susceptibility tested, it would be analyzed in the first option, first isolate only, but it would be excluded in the second option, which requires at least 1 antibiotic to be tested. In our work, we also consider the time interval. Take the patient's first isolate in a 365-day period. So if the patient had Escherichia coli 5 years ago, I will ignore that first one. If the patient had Escherichia coli 2 months ago, I will choose the one from 2 months ago. In Japan, I mentioned they go a bit further and they include the resistance phenotype. This does get a bit complicated to use 1 antibiotic, all of the antibiotics, what do you do with the intermediates, but I believe it is also very valuable for looking at different phenotypes and different clones as defined by their phenotype. I will now do a demonstration of WHONET in action using the default settings, and I will also start interpreting the results. When we get to the WHONET software, you will see that there are 3 analyses that include the option for cluster alerts. Isolate listing and summary. This will detect clusters without the antibiotic results. Resistance profiles. This will detect clusters, but it will focus on the multi-drug resistance profile. Those are the 2 core analyses. There is a 3rd analysis for cluster alerts, which is basically going to provide a subset of the first 2. In the first 2, for example, I will see all organisms, all locations, all resistance profiles. Some of them will have clusters and some of them will not. And that 3rd analysis, called cluster alerts, WHONET will only show you the organisms or the rooms or the resistance profiles with statistically significant results. So the 3rd option here is a subset of the first 2 options. And you can see these 3 options highlighted in green at the bottom of the screen. Each of these analyses allows you to access the options for cluster alerts. So I will focus on isolate listing and summary, resistance profiles, and cluster alerts, and I will not show you the options yet. I will just use the normal default options, and then after that, we will come back and discuss the options in greater detail. Next slide. So in the first example, I will choose the isolate listing and summary, comparing the organism and the specimen date, using all organisms, using 1 month of sample data, and I will look at the first isolate per patient per species per year. The first time I do this, I will not look for clusters in a statistical way. So I will just simply do a normal WHONET analysis for organism by date. I'm now opening the WHONET software. For purposes of this demonstration, I will choose the WHO test laboratory. The WHO test laboratory, we give you 1 month of sample data. So obviously with 1 month of sample data, it is not great for finding outbreaks. Normally, if you want to look for outbreaks, you would like to have at least 1 year of data, 2 years of data, 3 years of data. For today's demonstration, I will only use 1 month of data. That is a limitation because it's only 1 month of data. The reason I am doing this is so that you can repeat what I am doing on your own. So I do not want to give you 5 years of data from my hospital. Of course, I'm not permitted to do that. So in our tutorials, in our teaching exercises, we do use the 1 month of sample data for purposes of teaching. Just keep in mind, there is a limitation. It is only 1 month of data, and normally you would like to have at least 1 year of data. So I will choose the WHO test laboratory. I will click on Open Laboratory. I will go to Data Analysis. As I presented in a webinar a few months ago, we have Interactive Data Analysis at the top, followed by Quick Analysis at the bottom. Today, I will focus on the interactive analysis because I want to make all of the decisions about the analysis features. And later, or on part 2, I can talk about quick analysis. Quick analysis is very valuable if you would like to automate this. In my own hospital, we download the data every morning at 1 o'clock. We use Backlink to make a WHONET file at 1:15. We run a series of WHONET analyses at 1:30 to create a series of Excel or Word or text files that we can utilize on a daily basis for notifications of outbreaks or other important findings. So we can discuss that in part 2 of this webinar or part 3. But today I will focus on interactive data analysis. So here on the left side of the screen, you see the 3 required questions: analysis type, organisms, and data files. Under analysis type, I can see isolate listing and summary, resistance profiles, and cluster alerts. So today, those are the 3 features that we will look at. On the left, I will start with isolate listing and summary, and in the lower right, you see this feature called include cluster alerts. The first time I do this, I'm going to leave that off so that you can see manual visual outbreak detection. So I would like to do a listing, a summary, and I'd like to do organism by date. Row variable is organism, so there will be 1 row for each organism, and the columns will be the specimen date by month. I'm going to change this. We will only look at 1 month of data, so these graphs will be more interesting if I click on day. Okay. So I've only made 1 small change here. Organism by date, specifically by day. I will click on OK. Organisms. I will click on organism groups, and I will double click on all organisms. My options appear on the left. My selections I put onto the right. I would like to choose all of the organisms, and I will click OK. Under data files, here is the 1 month of sample data that we give to you for cluster detection. I can choose 1 file, I can choose 20 files, I can choose 500 files. You can choose the number of files that you would like. Normally, I would like to do cluster detection with at least 1 year of data. In fact, for our own work, usually we use 3 years of data in order to have 2 years of baseline data, and I will come back and discuss that further later. So I've chosen this 1 month of sample data. I will click on OK. I will now begin the analysis. Here I can see a list of all of my results, 1 row for 1 isolate. In the top left, you see that this database has 622 isolates. I will not look at this further now. I will click on Continue to move immediately to the summary. As I mentioned, there is 1 row for each organism. I see Acinetobacter baumannii, etc. I can look at the graph. Here is the graph for Escherichia coli. Is there an outbreak here? No, I don't think so. The numbers go up, the numbers go down. There is variation. There are probably fewer Escherichia coli on the weekends. The hospital is open, but the emergency room is open, but the clinics are closed. So you do see that there is a random variation. It's also a very wide random variation. I would not consider this to be normally distributed. You have a lot of ones and you have some 5s and 6s and 7s. So Escherichia coli has a lot of variability in how many you have every day. I'm going to start at the top of the list. A Chromobacter outbreak? No, it was just one isolate. Acinetobacter? I do not see an outbreak. No outbreak. No outbreak. No outbreak. Well, this one is interesting. If you look at January 25th, I see 8 people on the same day. Okay. I keep on going. That looks all normal. I don't see clusters here. But let me return to this option. And you can see that there are 8 people on January 25th. What I don't know is it the same people? Well, this is the number of people. So obviously this is concerning. There are many on the same day. Is that an outbreak? Personally, I don't think it's an outbreak for 2 reasons. Corynebacterium species, also known as diphtheroids, is not a very pathogenic organism. It does not cause a lot of severe disease. It does not generally cause outbreaks. So because of this organism, I don't think it's an outbreak. I'm not certain. It could be an outbreak. It is useful to remember that diphtheroids is a very common cause of contamination. So my first guess is that this is not an outbreak. My first guess is there's some contamination issue going on here. For example, there's a new student who did not clean the skin before taking a blood sample. So this is concerning to me, not from the perspective of outbreaks, but from the perspective of quality of care. Another reason I don't think it's an outbreak, it's unusual in an outbreak for everybody to be sick and diagnosed on the same day. So the fact that we have 8 people on the same day is suggesting that this is not necessarily an outbreak. It could be an outbreak, and I do want to investigate further, but my first thought is that this might be a contamination issue, which of course is also important. I'm looking at this and I can simply click on copy table, copy graph, so I can investigate this further later. It also reminds me that I did forget to remove the repeat isolates. So for example, on Escherichia coli, there were 86 isolates of Escherichia coli from 71 people. So some of the people had Escherichia coli more than once. I will click on continue, and I'm now back at the main screen. I did forget to remove the repeat isolates. So I can do by patient, but as I said, I'm going to do by time interval, first isolate only. Consider the time interval. For our own research work and for our own practical work, we use 365 days. The patient has Escherichia coli 200 days apart, we take the first one. If the patient has an Escherichia coli 4 years ago, I just ignore the one from 4 years ago. I will click on OK. I will begin the analysis again. And the repeat isolates have now been removed from this listing. There are no longer 622 isolates. There are now 551. I will click on continue. And now you can see Escherichia coli. There are 71 isolates from 71 people because I have removed the repeat isolates. I will now click on continue. I will now go back to my PowerPoint. That was the first example of manual outbreak detection, where you simply look at the graphs. But that's a lot of graphs to look at, many organisms, many rooms. So yes, you can do manual outbreak detection. And I do know hospitals that do this monthly. They look at the results once a month, and they have noticed outbreaks. So this is not a bad method. Many hospitals have found value in manual review on a monthly basis. But now we can look for cluster detection from a statistical perspective. I will do exactly the same analysis. but this time I will turn on the cluster alerts. I go to analysis type. So I hope that the analysis that I'm showing you here, I'm hoping that many of you have already done this analysis. It's a very simple and a common and valuable analysis. If I want to see cluster alerts, very simple. All I do is click here. Later today, we will look at the options. We won't look at the options right now. We'll just turn on the cluster alerts and assume that WHONET is going to provide some useful values for cluster detection. I will click on OK. I will click on Begin Analysis. The isolate listing has not changed at all. It's the same listing I showed you a few minutes ago. I will click on Continue. And now you can see the table has more columns in it. Most of the graphs are the same. Here's the graph for Escherichia coli. I'm going to start at the top again. No cluster, no cluster, no cluster, no cluster, no cluster. And now you can see that January 25th, I think that's 7 people on the same day appearing in red. Also, you will notice that on the previous time I did this, there were some diphtheroids after January 25th, but those were repeat isolates. Now that I've removed the repeat isolates, those have disappeared. So I thought there was a problem on this date before just because my eye told me it was a lot of people. But now I have it confirmed statistically. And here you have the details. The p-value is 0.0076. For those of you who have studied statistics, you will know that the smaller the p-value, the more unusual it is, outside of the range of normal expectation. Anything below p of 0.05 we consider to be statistically significant. It is an arbitrary limit, but the smaller the number, the more unusual this is, and it is probably not random variation. Something is going on. Something might be an outbreak, it might be a contamination issue, it might be a quality issue, but something is going on. And you can see there were 7 people, but on the basis of averages, I would only expect 1 person. So we have 7 people we observed when the expectation was only 1, and that's very statistically significant. Here I am going to click on cluster number once to sort the table. I'm going to click on it again. So that sorts the table. So you can see that there are 2 organisms at the top that have a statistically significant cluster. Here's one of them, the diphtheroids, and that's the graph we are looking at right now. The other one is Klebsiella pneumonia. Let me take a look at that graph. And here you see this graph that I already showed you during the PowerPoint. On January 28th, there were 2 people with Klebsiella pneumonia. Well, that's not unusual, that's normal. On January 29th, there were 3 people. January 30th, there were 5 people. So those 3 days together, there are 10 people. So that's a lot of people, much more compared to the first part of the month. Most days have 0 persons, 1 person, 2 people. But at the end of the month, we have 10 people in a 3-day period. That is statistically significant with a p-value of 0.022. Is that an outbreak? I don't know, but I'm much more worried about this one. Yeah, so what do I want to know next? Well, I want to know, were these inpatients or outpatients? Were they hospital infections? Were they in the same room? Did they have the same resistance pattern? I don't know that information right now, but I can find that information. So when I looked at the graph for diphtheroids, I'm not very worried about an outbreak, but I am worried about a quality issue. For example, contaminations. The Klebsiella, I am more worried that this might represent a true outbreak. By the way, these are real data. I did change the dates, I did change the patient identifiers, I did change the rooms, but the microbiology results, these are real data. So I am concerned about 2 possible clusters. That's very important. Also important is all of these other organisms looks fine, looks fine, looks fine, looks fine. So not only is it telling me which organisms have a statistically significant cluster, it's also telling me that these other organisms do not. So I don't want to ignore the other organisms completely, but I can pay less attention to them because there's nothing that is statistically significant. Of course, you can have a true outbreak that is not statistically significant, and vice versa. So I'm going to click on continue. Going back to my PowerPoint. Here, I have changed the analysis. Instead of doing isolate, listing, and summary, I'm going to do the analysis called cluster alerts. I go to analysis type. And instead of doing isolate, listing, and summary with the cluster alerts, I will click on cluster alerts directly. I will change the graph to be by day. And I will click OK, and I will begin the analysis. And now WHONET is not showing me the listing, it's showing me immediately the statistical results. You see the graph for the diphtheroids, you see the graph for the Klebsiella pneumonia. All of that is unchanged. What has changed is all of the other organisms have disappeared. So in this analysis, you get the exact same rows for the organisms that have clusters. For the other rows, they just simply disappear. Because this is what you want on a daily basis. I don't want to see all of the other organisms if there is no cluster. So this analysis is a subset of that first analysis where it is only showing me the rows that are statistically significant. There are three parts to the output. This is part one, which is the detailed report. This is part two, which is the summary report. And this is part three, which are the people. So for example, the diphtheroids, these are the 7 people involved in that cluster. Klebsiella pneumonia, these are the 10 people associated with that cluster. Now let me look at the Klebsiella pneumonia in more detail. You see cardiology, cardiology, cardiology. Cardiology appears here 1, 2, 3, 4, 5 times. The surge is cardiac surgery. There's intensive care unit, there's neurology, there's outpatient, there's neurology again. So this is also concerning for me from the perspective of a hospital outbreak. It looks like this might be a hospital outbreak involving cardiology and cardiac surgery, and maybe the ICU and maybe neurology, and one of them was an outpatient. Maybe the outpatient was part of the outbreak, maybe the outpatient has nothing to do with the outbreak. It's just coincidence, it's at the same time. I can look at the zone diameters. That's another thing I can look at. Are the resistance patterns the same? Are the results the same? I'm going to click on continue. Let's see. Okay, let me go back to my PowerPoint. I'm now going to move on to example number 2, where I'm going to do more or less the same thing, except I will not do all organisms. I will only do Staphylococcus aureus. And I will divide it by location and date. So I don't want all of the organisms. I can clear my list. I can enter Staphylococcus aureus, and I click OK. Analysis type. I don't want the rows to represent the organisms. I want the rows to represent the different locations. In this example, the location is the name of the ward or the name of the clinic. I will click on OK, and I will click on Begin Analysis. And let me continue, and continue, and continue. Analysis type. I just showed you the cluster alerts. I jumped ahead too fast. I want to go back to the beginning and choose Isolate, Listing, and Summary. This is going to give me all of the locations. I click on OK. I click on Begin Analysis. And here I see 76 Staphylococcus aureus, first isolate per patient. Continue. And I can now see the distribution. Oh, I forgot to do one more thing. Analysis type. You remember when I did cluster alerts, I changed this to location. However, listing and summary, I forgot to do that. So my rows, I don't want to see the organism. On the rows, I want to see the location. I click on OK. I click on Begin Analysis. The listing is unchanged. I will continue. And now I see one row for each location. Here's the graph for outpatient. I'm looking at many different graphs. And one of them has these red bars. And I had this example also in the PowerPoint. So all of these locations look like they have no specific problem with Staphylococcus aureus, except for cardiology. And here what you can see is that on January 18th, there were 3 people. January 19th, there were 2 people. So that's 5 people in a 2-day period, which is more than the Staphylococcus aureus in the rest of the month. So SaTScan is telling me that this has a p-value of 0.0267. The cluster dates is from January 18th to January 19th. It involved 5 people, but we would have only expected 0.83 people if everything were based on averages. The concept is similar to a chi-square. This is not calculated like a chi-square, but the principles are very similar. We observed 5 people, but if we take the averages, we would only expect 0.83. And the basis of the ratio of the observed to the expected, SaTScan is giving us a p-value of 0.0267. Well, to be more precise, it's using the Monte Carlo simulations, but the idea is similar to the way you would do this for a chi-square. So SaTScan is saying that this is statistically significant on January 18th. That doesn't mean it was the start of the outbreak. The outbreak might have started on January 16th. The outbreak might have started on January 5th. So SaTScan does not know exactly when these outbreaks start and when these outbreaks end. SaTScan simply tells you, this is statistically expected, this is statistically unusual. So if this is a true outbreak, I would still want to investigate January 16th and January 11th and do molecular typing, because they may have been a slow start to an outbreak. So the purpose of SaTScan is not to find every case in every outbreak. It's simply to tell you that the numbers are more than I would expect. So it helps you to find possible outbreaks, and then you can investigate them in further detail. So we have looked at outbreak detection by organism, and we have found potential clusters for diphtheroids and for Staphylococcus aureus. I made a mistake. We found clusters in that first analysis for diphtheroids and Klebsiella pneumonia. Here we have found cluster detection by location. We found most of the locations look fine. However, cardiology has more than you would expect in this 2-day period. I will click on continue. And then if I now go back to cluster alerts, and I click on OK, and I click on Begin Analysis, it is showing me the detailed report that I will discuss later. It is showing me the summary report. And here the difference is you only see cardiology. You do not see the other locations. So again, this is a subset of that first analysis. It's showing me the locations that are interesting. It is not showing me the other ones. And then when I click on continue, I can see the people. 5 people in cardiology. 3 of them were on January 18th, and 2 of them were on January 19th. 4 of them were blood, 1 of them was urine. And here I can see the zone diameters, and the zone diameters look very similar. So this is very consistent with the possible outbreak. I will click on continue. We'll now go back to the PowerPoint. Example 3, we will stay with Staphylococcus aureus, but now we will utilize the resistance profiles. So the rows will be the resistance profiles and the columns will be the days. I'm going to make another change here. Before we looked at first isolate per patient per species, this time we will include the antibiotic results. So I can go back to WHONET, analysis type. Now I can jump to resistance profiles. Listing, summary, both. specimen date by day. The row is the resistance profile. And I want to include my cluster alerts. I click on OK. I click on Begin Analysis. The focus of the December webinar was WHONET and multi-drug resistance profiles. And this kind of example is what I showed in the last webinar in November. These isolates at the top are sensitive to all of the antibiotics. Here we have 4 isolates that are resistant to one drug, erythromycin. Here we have many isolates that are resistant to penicillin. Here we have 2 isolates resistant to 2 drugs. We see isolates resistant to 3 drugs, resistant to 4 drugs. Here at the bottom, we see Staphylococcus aureus resistant to 7 antibiotics. These are multi-drug resistant. You see that one of the drugs is cefoxitin. Therefore, these are MRSA. These 3 are also MRSA. These 2 are also MRSA. So not all MRSA are the same. These 3 MRSA have interesting locations. 2 of them were in oncology and 1 of them was in the outpatient area. So it is not a surprise that we have multi-drug resistant MRSA in the oncology unit. It's a little unexpected to have those same MRSA in an outpatient, but you have to keep in mind, not all outpatients are healthy people. These might be former oncology patients, or they might be current oncology patients who went home, or they might be a family member, or they may have some other risk factor. So the multi-drug resistance pattern tells me more about the epidemiology of this particular strain. Not from a genotypic perspective, we don't have that information, but from a phenotypic perspective. Now going to click on Continue. And here I can see the distribution of all of the resistance phenotypes. Here at the number of isolates, I click once, I click again. The most common phenotype in this database is Staphylococcus aureus resistant to 1 drug, penicillin, followed by resistant to 2 drugs, penicillin and erythromycin. Here's that example we just discussed, where we have 3 isolates from 3 people resistant to these 7. I can see the distribution over time. Here I can see the graph for the sensitive Staphylococcus aureus. Here at the bottom, I can see the graph for the multi-drug resistant MRSA. I can look at all of the different graphs. I do not see any. Well, this one's interesting. I see 5 isolates on the same day with this one resistance pattern, but it was not statistically significant. I'm going to continue further, and this is the only one that came up as statistically significant. I can also see that in the table. Of all of these different resistance patterns, only one of them was statistically significant with a p-value of 0.0007. So what do we have here? We have 4 patients on the same day, resistant to 1 drug, erythromycin, and nobody else in the rest of the month. So this is very unusual to have 4 people on the same day with the same resistance pattern. In fact, if I will now go back to the isolate listing. And here are those people. I showed you these 4 people earlier. What I did not show you is that the date was January 22nd. 3 of them were in blood, 1 of them was in urine. So this is very statistically unusual. It might be an outbreak, it might be a contamination issue. I have reason to think that this might be a quality issue. Or not necessarily a quality issue, but I suspect it might not be an outbreak. I will look at the erythromycin, and you see that one of them is a zone diameter of 6 millimeters, highly resistant. 2 of them have zone diameters of 11 and 12, moderate resistance. One of them has a zone diameter of 22 millimeters. And as you can see at the top, 22 millimeters is 1 millimeter away from being susceptible. So I don't think this is an outbreak because it seems to be 3 different Staphylococcus aureus. One is almost sensitive, one is very resistant, and 2 of them are moderately resistant. So the zone diameters can help you to decide whether or not they seem to be related. If you are very concerned, of course, you can do molecular typing. Continue. And I just showed you this. So yes, we have here many, many resistance phenotypes, but only one of them was statistically significant. I will click on Continue. Analysis type. I will now choose Cluster Alerts. When I did this before with the Staphylococcus aureus, I chose Location. This time, I'm going to the very bottom of this list, and it says Resistance Profile. It's important. It's a little hard to find. It's at the bottom of the list. But now I can do a resistance profile. I click on OK. I click on Begin Analysis. This is part 1, the detailed report. Part 2, the summary report. Part 3, the list of those 4 people. We already saw that all 4 of them were on the same day. 3 of them were in blood. 1 of them was in urine. What I did not mention is that 3 of them were in the emergency room. So if this is an outbreak, it's not a hospital outbreak, it's a community outbreak with 3 people coming to the emergency room and 1 person directly into the intensive care unit. Continue. So I would think this does merit further investigation. I don't think it's an outbreak, but it's still worth investigating the epidemiology, the quality. Maybe these are penicillin resistant, but the laboratory made a mistake. Good. So I will now go back to my PowerPoint. Checking the time. We're doing well. And the last example, I'm going to put 2 variables, location and resistance profile. So before you saw that the rows were the organism, or they were the location, or they were the resistance profile. This time I will bring together the location and the profile. I click on Analysis Type, and I will put location as my first variable, and I will put resistance profile as my second variable. I click on OK. I click on Begin Analysis. And here you can see 2 statistically significant clusters. Unfortunately, you do not see the graph. We have not yet made WHONET smart enough to do the graphs when there are 2 variables. That's something we will do eventually. We can do it, but we're busy people, and making graphs for 2 variables is not one of our early priorities, unfortunately. So what are these 2? You saw earlier for stuff. Let's focus on number 2 here. Here you see a statistically significant cluster of erythromycin resistance in the emergency room, and there were 3 people, but that's exactly the example we just talked about. We saw 4 isolates on the same day. 3 of them were the emergency room, and 1 of them was in the intensive care unit. So here, because I'm focusing on the room, I see that same cluster. I don't see all 4 patients, but I see 3 of the patients because the 3 patients were in the emergency room. So this is reinforcing what I saw in my previous analysis. Emergency room, erythromycin resistance, 3 patients on the same day. And the p-value is 0.0159. Here, we have also seen this previously. I showed you an example with Staphylococcus aureus by location, and you saw there were 5 people in a 2-day period, if you remember that. I did Staphylococcus aureus and location, and I found a cluster in cardiology. This analysis is going even further. Not only are they in cardiology, they have the same resistance pattern, which was resistant to penicillin and erythromycin. So not only do they have the same room, They have the same resistance pattern. So it's highly suggestive that something important is going on. It might be an outbreak, it might be a contamination issue, but this is something that certainly requires further investigation. I will now continue. That was the detailed list, the summary list, and finally the list of the people. So here are those 5 people that I just mentioned in cardiology. 4 of them were blood, 1 of them was in urine, 3 of them were on January 18th, 2 of them were on January 19th. So all of that we saw previously. And here you see the zone diameters to show you that they're all very, very similar. We'll continue. I will now go back to the PowerPoint. So possible explanations of statistically significant clusters. Obviously, there might be a true outbreak, an inpatient outbreak, an outpatient outbreak, an inpatient or an outpatient outbreak. You also may have these pseudo outbreaks. I gave examples of contamination, potentially with the diphtheroids, or poor quality of laboratory reagents or contamination of the laboratory materials. There might be changes in sample collection practices. For example, maybe we are doing a lot more screening than we used to. There might be changes in laboratory test practices. For example, if I give a training course on anaerobes, maybe next week you will start to find a lot of anaerobes. That's not an outbreak, that's simply better detection of what was always there. We have seen this in a number of countries when they switch from manual methods for organism identification to machine methods or kit methods. For example, I've seen many laboratories that have an organism at the beginning of the year called Klebsiella species, but then at the end of the year they call it Klebsiella pneumonia because the capacity has improved. So it looks like there's an outbreak of Klebsiella pneumonia, but there isn't. It's simply better detection of the Klebsiella pneumonia that were always there. But previously they were called Klebsiella species. Similarly, you have laboratories that change from an organism called coagulase negative Staphylococcus to later Staphylococcus epidermidis. A lot of them it's the same, but it's improved laboratory capacity. You might also have changes in patient populations, or it just might simply be random variation. Of course, with random variation, of course, sometimes the numbers will increase. I forgot to mention here about food and animal sampling. A lot of times this is when people take samples from animals, sometimes they take samples from sick animals. That's relatively consistent. There's a baseline, sick animals, there's an outbreak, you have more cases. However, many times people take samples of healthy animals, and maybe they'll do it 1 day a month, maybe they'll do it in January and they'll come back and do it again in May. Those are not outbreaks, that's simply irregular specimen collection. You might find an outbreak in January, but that's not an outbreak. It's just they're doing all of their sample collection at the same time. So there are a number of reasons why you see these statistically significant case clusters. It's not a failure of SaTScan if it's not an outbreak. SaTScan is helping you to find statistically significant clusters, and that's SaTScan's job. It's your job to decide whether it's an outbreak and what should be done about it, or is it a quality issue? So now we're going to discuss some of the options. Right now, I just accepted the default options. So we're going to see this screen, and you can see there are different options for the analysis method, start date and end date, maximum cluster length, baseline data, p-value, Monte Carlo simulations, and then additional information. The first question here is the analysis method. We can ask this as a retrospective question, a prospective question, or a simulated prospective question. If we run this as a retrospective question, that is an example of that is asking the question, do we have any statistically significant clusters in 2023? You run the analysis once, the answer is yes or no. So that's a retrospective question. Were there any outbreaks last year? And so far, all of the examples I've shown you have been retrospective analyses. That is an interesting question. Prospective is more for real time going forward. It's a single question. Were there any outbreaks on August 15th? Were there any outbreaks on December 5th? And that's an interesting question for that one day. What we do mostly for our research is simulated prospective. So this does address the question, did we have any outbreaks in 2023? But in a different, it's asking the question in a different way. What statistically significant clusters could we have detected in 2023 if we had been doing the analysis every day of the year? The retrospective analysis is an interesting question. Did we have any outbreaks last year? But the simulated prospective analysis is a more interesting question because it helps you to predict what you would like to see in the future. If I look for outbreaks every single day going forward, that is interesting for me in terms of my responsibility as an infection control person in a hospital setting or at a national level for national outbreak response. Okay? And I can do that using the historical data. So let me start off with that. I'm back in WHONET. I go to analysis type and I will go to cluster alerts. That's fine. Let me choose something very simple. I'll go back to where we started. I will just choose the organism as my row variable. I'm just going to remind you of what the output looks like. Let me put all organisms again. So you've already seen this. There will be two organisms, the Klebsiella and the diphtheroids. Adam, there seems to be a small bug, I think. We're supposed to see the graphs here. So I'm guessing once we go from two variables back to one variable, we're turning off the graphs. Let me just verify if that's correct. I'd like to show you the graphs. So I'm going to let me just leave WHONET completely. Let me start WHONET again. WHO test laboratory, data analysis, analysis type, cluster alerts, organism by day, okay. All organisms, 1 month of sample data, begin analysis. Yeah, so we have the graphs back. So you've already seen this, the 7 diphtheroids on the 1 day and the 10 Klebsiella in 3 days. Part 1 is the detailed report, part 2 is the summary report, part 3 is the list of the people. Now I'm going to click here on options. We have not looked at options yet. Now I'm going to do prospective analysis. And it's not going to find anything very interesting. Let's see. It did not find anything at all, and I will explain why. It is looking for outbreaks on the last day. It is looking for outbreaks on January 31st. And it said, I did not find any outbreaks on January 31st. Okay. I can change it to look for outbreaks, for example, on January 25th. On January 25th, there seems to be a cluster here. We've seen this. So with a prospective analysis, it's only looking at 1 day. If I look at January 31st, it did not find any clusters. If I look at January 25th, it finds this one cluster. Or if I look at January 30th. Okay, begin analysis. And it finds the Klebsiella. So in a prospective analysis, it's only looking for new recent clusters on a specific day. We had the diphtheroids cluster on the 25th, the Klebsiella cluster on the 30th, and nothing on the 31st. Sheet 1, sheet 2, sheet 3. Good. So of course, we never do prospective analyses manually. Now I will continue with simulated prospective. Okay. I'm going to click on Begin Analysis, and when I do that, you're going to see the software analyzing January 1st, and then January 2nd, and then January 3rd. It will continue to analyze every single day until it gets to the end of the month. Begin the analysis. So in the lower left, it says January 15th, January 20th, January 30th. It has just done 31 analyses. When it did the 31 analyses, it is now showing us, in fact, it's showing us the same two organisms, the diphtheroids and the Klebsiella pneumonia. But this time, it is not showing me the p-value any longer. It is showing me the recurrence interval. Should I talk about that now or later? The recurrence interval is simply 1 divided by the p-value. So the p-value, the traditional p-value for statistical significance is p of 0.05. But 0.05, as you know, is 1 out of 20. So the idea of a p-value is that something is unusual if it happens by random chance less than 1 time out of 20. And that's the reason why we choose a p of 0.05. If it happens like 1 time out of 3, that's not unusual. If it happens 1 time out of 50 experiments, that's unusual. And somebody arbitrarily said 1 time out of 20 is where we want to draw the line between significant and not significant. And it is just an arbitrary threshold. There's nothing magic about it. So we don't use, and we do use the p-value as our threshold for retrospective analyses because it's a simple one analysis. So anything below 0.05 could happen by random chance 1 time out of 20 experiments, but we only did the experiment once. The problem is if you start doing analysis every day, you're going to have a statistically significant result on average every 20 days. So if something happens every 20 days, that's not that interesting from an infection control perspective. So we look at the recurrence interval. We don't want a statistical significance of 1 every 20 days. We might want like a once in a year event. So I'm going to go to Excel. I'm going to do 1 divided by 365. That is 0.00274. So if you have a p-value less than 0.00274, that is what we would consider to be a once-a-year event. So the smaller the p-value, the higher the recurrence interval. So let's see. Here you see the recurrence interval is 2356. 2356 divided by 365. Let me make these numbers bigger. That's approximately 6.5 years. So this graph I'm showing you right now could happen by random chance. It could happen by random chance if I gave you 6 years of data. But I didn't give you 6 years of data. I gave you 1 month of data. So we're seeing a once in a 6-year event in a 1-month period, which is very much beyond normal variation. So this is suggesting that this is probably not random variation. Something is going on, such as an outbreak. Regarding the diphtheroids, equals 7946 divided by 365, 22 years. So this graph that I'm showing you now could happen by random chance. Of course, strange things happen by random chance, but this random chance event is the kind of thing you might see once every 22 years. But we didn't have 22 years, we only have 1 month. So the recurrence interval is more meaningful when you're doing prospective work. I don't want to use a p-value of 0.05 as my threshold because then WHONET will throw up statistical significant results every 20 days on average, which is consistent with random variation. So that's why the recurrence interval is more meaningful when you're doing something prospectively every day. Okay, good. This is the detailed report. This is the summary report. And then this is the listing. I will explain later what the difference is between the detailed report and the summary report. It was Excel. Whoops. Good, that's good. And I'm back here. Let's see. So I have shown you the difference between retrospective, prospective, and simulated prospective. So with simulated prospective, we are marching through the database, and every day we have the same question. Do we have an outbreak today? Do we have an outbreak today? Do we have an outbreak today? And then WHONET summarizes that into the output that we just saw. I will now talk about the difference between spatial, temporal. And here you can see the list of the options that WHONET offers. The three that we primarily use are space-time permutation for our older papers, space-time uniform for our newer papers, and spatial multinomial. The CDC algorithms are also here: QSUM, mild, medium, and ultra. They are strange names. I don't know why those names are there. So let's see. I'll go back to WHONET. Options. And here I can choose space-time permutation, space-time uniform. I won't do that because space-time uniform is not going to work with only 1 month of data. It needs more data than that. Let me actually just try it. I've actually never tried it. You can see in the bottom, it is marching through the database. Well, it's sort of, yeah, this is not interesting. It's looking at the data before. It's looking at 1 year of historical data, but there are no historical data. So I'm not going to discuss this one further because space-time, see, this is not interesting. Let me go back to that screen. We have found, generally speaking, that space-time uniform is giving us better results. However, it does need real baseline data. And with 1 month of data, I do not have real baseline data. Space-time permutation does not have that same assumption. So that's one advantage of space-time permutation, but it's not a real advantage because in real time, you always have baseline data. So for this demonstration, I will stay with space-time permutation. Other parameters, start date and end date. So I have shown you cluster detection for every day of the month of January, but sometimes you do have a particular interest on a start date and an end date. So I already showed you an example with January 25th and January 30th. Maximum cluster length, I will come back and discuss that in a few moments. Baseline period, I was just talking about that. We use this for prospective analyses. Please compare the results from this week to the last 1 year of data, to the last 2 years of data. So we're only comparing with data in the past and that's why the space-time uniform did not work, because there is no historical data. For retrospective, you don't need historical data, you just need a time period. If it looks for clusters in 2023, it will compare the December data to January. It will also compare the January data to December. So for a retrospective data analysis, you do need data, but you don't need historical data. You just need the data for the time period that you are interested in. But for prospective analysis, of course, in real life, we do not know what's coming ahead. We only can look at what's in the past. So for a prospective analysis, you do need to provide it with historical baseline data. We also can look at the p-value threshold or the recurrence interval threshold and additional information. So I will come to those. Let me go back to WHONET. And here you can see when I select retrospective, it is not asking me about the baseline data. It doesn't need baseline data. It just needs the analysis time period. But for prospective or simulated prospective analyses, it's asking me how much historical data do you want WHONET and SaTScan to look at. So that's the baseline data question. I will now look at the p-value question. The p-value by default for a retrospective analysis is 0.05. I'm going to put something very high, p of 0.5. That's a very high p-value. And let me rerun the analysis, begin the analysis. When I ran this before, you saw the Klebsiella pneumonia with a p-value of 0.0139. You saw the diphtheroids with a p-value of 0.0036. Now you see the graph for Providencia stewardii, and you can see that the p-value is 0.0532. So it is not less than 0.05, which is why you did not see it previously. But now that I set the p-value to a higher number, 0.5, I can see this now. So by changing the threshold, I can see more. This will generally improve the sensitivity. I am seeing more clusters that might be true clusters, but they might not be statistically significant with a p of 0.05. Or it might also be more random variation. So by going up on the p-value, I generally will improve my sensitivity, and I will find more true clusters, but I will also worsen my specificity. I will start seeing things that are there just simply because of random variation. So if you are doing publications, the traditional is 0.05. But keep in mind, we're not trying to publish, we are trying to save lives. So in my own hospital, I would rather to have a better sensitivity to find more true outbreaks, even if my specificity is worse. You do have to be careful about that because at some point you might start to have too many false positives. And with too many false positives, then people stop paying attention. But you don't have to simply say it is or it is not statistically significant. You can tell them the p-value or the recurrence interval, and then people can make their own decision. For example, with the recurrence interval, if the recurrence interval is 5,000 days, that's very statistically significant. On the other hand, if the recurrence interval is 9 months, 9 months, means that this might happen by random chance every 9 months. And that might be a true outbreak or it might be random variation. So if I see the recurrence interval, I can make my own assessment as to whether I want to investigate or not. If the recurrence interval is 5,000, yes, I want to investigate. If the recurrence interval is like 3 months, 8 months, I can use my judgment as to how important this is. It might depend on the room. If it's the neonatal ICU, I would like to investigate. If it is CRE, I would like to investigate. So you can use your judgment based on what the recurrence interval or the p-value is. So as you can see, the purpose of the threshold is that you can go up and down on the sensitivity and specificity by changing that. Part 1, that's part 2, that's part 3. I'll make a small comment there. Part 1, I clicked on continue. And then I clicked on continue, and I clicked on continue again. If you do not want to click on continue, I can simply click on file, stop analysis. That just stops everything immediately. So you do not have to do continue, continue, continue. I chose a p-value threshold of 0.5. Now let me put a p-value threshold of 1. Statistically speaking, that is meaningless. Let's just see what happens. So here you see a lot of garbage. And as you can see, this is interesting. It goes up to 7. What is this? This is the end here. Well, let me go to the p-values. So all of these, basically, I went up so high on the recurrence interval, on the p-value, that I'm getting a lot of garbage here. So there's a balance. You want to improve your sensitivity, but you also don't want to worsen the specificity too much. Okay. Analysis type and options. There's a feature here called Monte Carlo simulations. You can change that between 999, 9999, and 99999. This simply impacts the statistical precision. If you want to do an experiment, you can do the experiment 10 times or 100 times or 1,000 times or 10,000 times. On average, you will always get the same result. They will have similar accuracy. However, the more times you do the experiment, the more precise the answer will be. So we just put this basically at 9999, which gives us good performance. If your computer is too slow, then change it to 999. You'll get more or less the same results, but it will go faster. Or if you want to be extremely precise, change it to 99999, and then you'll get a more precise answer, but it will take longer. I'm going to put 99999 now. And as you can see, it did take a little bit longer. But if you have a slow computer, you can tell the difference. That particular feature we don't change very much. I'll now talk about the maximum cluster length. The maximum cluster length is not the maximum length of an outbreak. The outbreak might be 4 months long, 8 months long, 3 years long. That's not what this question is. This question is how many days of data do you want SaTScan to evaluate in terms of cluster detection? And I mentioned there is a scanning window. SaTScan will look for clusters of 1 day, and 3 days, and 5 days, and 10 days, up to the number that you set here. So for example, in our early work, for community outbreaks, we set this at 30 days. The idea is basically, if you have a community outbreak and you're trying to look for community outbreaks, you'll probably know within 30 days whether there is an outbreak or not. For a hospital outbreak, sometimes 30 days isn't enough, so we put this at 60. A hospital, the numbers are so small. In a normal month, there might be 3 or 4 or 5 people with Klebsiella pneumonia. And if you have a month with 7 people, it's a little bit higher than normal, but it's not very much higher. So you might want to take 2 months to decide whether or not you have a cluster period. So SaTScan will look for clusters of length from 1 up until the number that you do here. In our early work, we put 30 days for community outbreak detection and 60 days for our hospital outbreak detection. However, we did find a number of true outbreaks where 60 days wasn't enough. We had an example from a neonatal intensive care unit where there was a true outbreak, and the first isolate was at the beginning of May, and the second isolate was at the end of July, and that was more than 60 days apart. So we decided to open this window up to 180 days. So that's what we are currently using. So SaTScan is using 180-day maximum cluster length to find potential outbreaks of 1 day or 30 days or 60 days up to that. We have had good results with this, but I don't want to say that what we have done is optimized. We encourage you to question some of these, play around with the parameters to see what you find works best in your situation. Also, I mentioned regarding the baseline data, with all of our early papers, we used a baseline period of 1 year. But for these very small outbreaks of MRSA in the NICU, we just found that 1 year, that 1 year was enough data for a lot of things we wanted to find. 1 year of historical data was very good. But for a lot of the small outbreaks in locations like the NICU, 1 year of data wasn't enough. So in our current work, we now set this to 730 days, which is 2 years. So you can play around with this to see what you have. So we at the Brigham, we have data going back for over 30 years, 35 years. So we have a lot of historical data. If you don't have a lot, if you only have a little bit of historical data, you really should focus on retrospective analysis because to do prospective, you really need at least 1 year of data for the best results. If you have less than 1 year of data, stay with retrospective. If you do have 1 or 2 years of data, then simulated prospective will give you a better idea about the past performance of the algorithms as a prediction of the future benefit of the algorithms. So let's see, I think I've talked about most of those. Let me talk here about additional information. Anything else in the PowerPoint here? Parameters? Okay, let me just talk, repeat some of the things I just said. Start date and end date, we talked about that. Maximum cluster length. SaTScan scans a range of time windows to decide whether there are statistically significant case clusters. The size of the scanning window varies from 1 day up to the value that you select for the maximum cluster length. This is not the maximum length of the cluster. That's an epidemiological concern. The outbreak will end whenever it wants to end. But it's the size of the time window that SaTScan is evaluating. So if you're looking for outbreaks of Ebola, 1 or 2 weeks of data is enough. You look at the incubation period. If you're looking for an outbreak of salmonellosis, 30 days is generally enough. If you're looking for an outbreak of Klebsiella pneumonia, 60 days is usually enough. I said usually enough, and I think that's true. However, we did miss some of our important outbreaks when we limited to 60 days, which is why we now go up to 180 days. Baseline period, this is used for prospective analyses. How much historical data should be analyzed? For retrospective analyses, we look at the p-values. For prospective, we look at the recurrence interval, which is the inverse, and then additional information used to define code groups, such as in my hospital, we have the 4th floor. We have 4A, 4B, 4C, 4D. And SaTScan can look at those 4 units individually. SaTScan is also smart enough to look at the 4th floor as its own location grouping. Or in a hospital network, we can say that each hospital we can analyze separately. We can also analyze groups of hospitals at the same time. So that's what we mean here by additional information on grouping. In the past, we used simulated prospective with space-time permutation, maximum cluster length of 30 days or 60 days for community and hospital outbreaks with 1 year of historical data, where the recurrence interval threshold of 365 for our publications. For our internal work, we can go down below that just to get an early warning. For our newer publications, we continue with simulated prospective. We have changed the space-time uniform. We've used 180 days for hospital outbreaks. We're not doing community outbreak evaluation right now, and we use 2 years of historical data. Okay, good. Let me go back to organism. You can put the latitude and longitude, but that doesn't make any sense for organism. I showed you that I can choose the variable. So for example, for my row variable, I can put the patient's home location, if I have that, and I have the GPS coordinates. Or I do have the location of the laboratory. It could be a hospital laboratory, a community laboratory, a food laboratory. So if I put laboratory, I do have the ability to put the latitude and longitude of the laboratory or the clinic. Or instead of using latitude, longitude, I could say that these hospitals belong together. These clinics belong together in a non-parametric way. Or if I put location, I can say the 5th floor. I can say all of the intensive care units is a group. So I can look at individual wards or I can look at groups of wards. And we have found that very valuable for finding outbreaks that involve more than one location. You might have a true outbreak involving only the room 5A. However, in the reality, a lot of times the outbreak might be predominantly in 5A, but also in 5B, also in 5C. So the code groups allows you to do that. Okay, back to the PowerPoint. That's a subset of everything that SaTScan can do. I'm just going to show you the SaTScan software. So we don't teach people SaTScan. If you want to learn SaTScan, you can. Everything that we have done ourselves in SaTScan is in WHONET. But some people want to do their own thing. So this is the SaTScan software. I choose my input data, my analysis type. purely spatial, purely temporal, retrospective, prospective, Poisson, multinomial, high rates of infection, low rates of infection or cancer, and then the outputs. So if you want to learn StatsScan for your own research purposes, you certainly can do that. We'll now go to a web page, statscan.org. So the software is here. It's a free software. I go to download, and download. And apparently the page is going slow for me, but there's a bibliography, and you register, and they send you the free password. Bibliography. You can see that StatsScan is used for psychiatry, obesity, cancer, accidents, astronomy, and Stelling. So we use it for, what is this? Food and waterborne disease. We did this with Salmonella Shigella. If I look for Stelling again, we did it for hospital infections, antimicrobial resistance. So StatsScan has a lot of capabilities beyond infectious diseases. It's widely used by public health departments. Examples from the literature. And I'll show that in a moment with PubMed. Go to PubMed. My name Stelling is a simple name, but it's not a common name. If you simply look for Stelling and StatsScan or WHONET and SaTScan, you'll find relevant papers. Once StatsScan is finished, what do you do next? StatsScan is there to help you find clusters. This is an example from NYU Medical Center in New York City, and they take the WHONET-SaTScan results and they decide high, medium, low risk. Do we need an intervention? And they can say, let's do molecular typing. Let's contact food services. Let's do some extra swabbing. So StatsScan is only the beginning to find you these potential concerns that might be quality issues, that might be outbreak issues. So New York Medical Center has done a nice systematic way going forward on how to investigate and work up and confirm and respond to potential outbreaks. Let me now go to PubMed, and I do apologize for going late. PubMed, sorry. Okay, PubMed. If I look for Stelling antimicrobial resistance, you'll find most of my publications. Most of these are me. If I look for Stelling and StatsScan, we have 10 publications out. I'll start at the bottom. We looked for outbreaks of Shigella and Salmonella in Argentina. First, we did that as in a simulated prospective way, and then we did true prospective with confirmation by PFGE, and then later by whole genome sequencing. And then we did analysis with a single hospital, and then we did interventions, and then we looked at a network of hospitals, and we looked at outbreaks in Japan, we looked in Italy, we looked in Vermont. So these are just different examples of how we have worked with this. This publication on geographic clusters is not about outbreak detection. It's about finding clusters when you have more or less than you would expect. I'm going to exit this because of the time. And there was just one last slide, which was simply thank you for your time. So I will stop speaking. Adam, I have not been looking at the questions. So Adam, if you could take the lead. I'm happy to stay on for the next half an hour for any questions that come up. If you do have to drop off in the next few minutes, feel free to do so. So thank you.
Hi, John. Yeah, there were just a few questions. So if you could just scroll up through the chat, let's see. And again, if anyone has any questions, this would be the time to type those into the chat, and we'll get to those in order.
Okay, I'm reading the questions. Okay, can the software be used for ambulatory centers or outpatients? Yes, definitely. And food and veterinary. And so we do have some of those publications on Salmonella Shigella, for example. Patient sharing rates are the best metric for HI spreading between hospitals. And Susan Huang, who is the principal investigator for a number of our papers, has done a very nice work at looking at MRSA spread and other kinds of spread, looking at patient transmission and exchange metrics. Okay, and then that's from Adam. Let me see the screen recording. WHONET is not yet web-based. Right, so we are slowly working on a web solution. It will take quite a long time. It's a large job to do. However, there are places that do collect the data nationally monthly. There are also 2 countries that collect data, or 3 countries that collect the data at the national level automatically every day. So it is conceivable with the desktop software to have automated daily data collection using secure file transfer protocols. So if that's an interest of yours, you can write to us and we can give you more background. Obviously, for a hospital outbreak detection use, you don't need a national system. So hospitals can already benefit from this locally. At the national level, you would like to have, for example, data monthly, and then you can look for outbreaks once a month. And many countries collect data on a monthly basis. And then 3 of the countries do collect data on an automatic daily basis with the desktop application using secure file transfer. Okay, wouldn't it be useful to consider as outbreaks only clusters determined by healthcare associated spreading? Well, what we are doing, the only data that WHONET has access to is the laboratory data. We don't have access to information on catheters and surgeries and diagnoses. We hope to have the data at least on date of admission. Many places can provide that, other places cannot provide that, because the date of admission helps us to separate community infections from hospital infections. It's not perfect, but it is a simple metric. It's interesting what NYU Medical Center does is they use WHONET-SaTScan for outbreak detection, but when they investigate, they have another database that has all of the healthcare workers. They know the doctors and the nurses and the students and the respiratory therapist and the physical therapist. They also know the surgeries. So they have a lot of information that they utilize to evaluate the statistical signals that they find. Let's see. Oh, hi, Liz. Sheikh from Malta. If we have date of admission in our database, can we do cluster analysis for only those that are on day 3? Yes, you can do that. And I will discuss that on the next webinar. I mentioned today, I just did simple filtering. I just did first isolate per patient. All of those clusters I showed you were a potential mixture of inpatient and outpatient results. What we can do with the date of admission is we do a few steps. We don't want the patients. One thing we can do in one step is simple, but it's not good. We can take the patient's first isolate on hospital day 3 and later. That sounds good, but it's not good if the patient already had an outpatient isolate or if the patient had an isolate on hospital day 1. So we don't want the patient's first isolate on hospital day 3 and later, unless if it was their first isolate. If the patient had an isolate on hospital day 1, I don't want their isolate on hospital day 10 because they had it on hospital day 1. So what we do is a series. Step 1, take the big WHONET database and make a smaller database with first isolates only. So that's a smaller WHONET file. And then we take that file and then we filter it again and take those first isolates if they were on hospital day 3 and later. So that's 2 steps. Other potential steps to filter first on CRE, filter first on screening, exclude or include screening. So I will cover that in the follow-up webinar on more advanced filtering to clean up the data before you start doing your outbreak detection. I wanted to find out, this is another question, I wanted to find out if the resistance phenotype can be given by class. For example, 3rd-generation cephalosporins being picked up by different phenotypes. It's something that's partially implemented in WHONET. Some of our analyses look at the ATC class or the WHONET subclass or subclass. I can show an example of that. Sharing my screen right now. And share, oh, I guess I was sharing my screen, sorry. Share screen, and let's see, WHONET. So this was also asked in a previous webinar.
John, we can't see your screen.
Oh, sorry, okay. Share. There it is, thank you. So
Yep.
You can see the screen now?
Yes.
So as an example, if I go to resistance profiles, and I'll just do the same analysis that I showed you, and let me show the clusters. Include cluster alerts, yes. And organisms, I will put Staphylococcus aureus, and I will put data files. Okay, begin analysis. So here I showed you this already with the statistically significant cluster of the erythromycin resistance. There are some columns that are hiding here. I'm going to show hidden columns. So the classes are here. Erythromycin is a macrolide. Penicillin, fluoroquinolone, sometimes it's a class, sometimes it's a subclass. Folate. So the information that you're requesting is here, but we're not using it for cluster detection. The question that you have asked is, people ask much more often about antibiograms. You know, if you're a national coordinator and some of your laboratories test imipenem and some of your laboratories test meropenem, it would be nice if we could average them together. Or if some test cefotaxime and some test ceftriaxone. So in WHONET, we have partially implemented classes and subclasses, but we're a tiny development team and we just haven't had time to do that. So yes, the answer is that it will be possible once we get to it. Let me think. I hadn't really thought of it. I don't know if this will work or not. I never tried it. As you know, I did resistance profiles here. There is another option called resistance classes. This might work. I never tried this before in association with outbreak detection. Let me click on OK. Let me click on begin analysis. Okay, and I was looking for a potential outbreak among the macrolides. Okay, so apparently it almost works, but I think we just need to do a little bit more work. So Adam, if you could just note that down. I never thought of trying it this way, but for his specific question, it looks like WHONET almost does it.
Hey, I'll keep that noted down here.
Notes. Oh, hi, Billy. Nice to see you. I assume they will appear after the tool. Very present. Thank you. I'm happy to stay on longer. I've got nothing else to do. I'm home in Boston. I'm here for 2 weeks, and then I will go to Mexico for a project on pertussis with the American Society of Microbiology. How should we tune the max temporal size parameter? I think SaTScan has a ton of features that we do not utilize, as I showed you. Max temporal size, I think that's the same as the max cluster length. If it is, what I did initially in around 2008, when we started doing this kind of work, is I tried the max cluster length of extremes, 7 days, which might be appropriate for Ebola. 7 days, 15 days, 30 days, 60 days, 90 days, 180. Those are the values that I evaluated. And the first thing that I found is most of them found the same clusters. If you chose 15 days was a bit short, but if you chose 30 days, 60 days, 90 days, most of the clusters are the same. It's very robust. Obviously, if you look at 30 days as the maximum, you will not find anything that takes 45 days to manifest itself. If SaTScan is not sure in 30 days, it will not find it if your limit is 30 days. So that's the advantage of the longer time periods, which is why we eventually ended up with 180, so that we were not missing anything. But I didn't mention there's also a downside. If I'm looking for 180 days clusters, from 1 day to 180 days, the benefit is I can find these very slow, gradual outbreaks. The disadvantage is from the statistical perspective. It's this thing called multiple comparisons. It's looking for 1 day and 3 days and 4 months and 5 months. So the more comparisons that you do, you decrease your power. SaTScan is smart enough to deal with these multiple comparisons. And the more comparisons you do, it is what we call a fishing expedition. Let me try this analysis and this and this and this and this. And the more analyses you do, the more likely you're going to have an artificial positive. So SaTScan is smart about controlling for multiple comparisons. So the advantage for us now to use 180 days is we have the ability to find these long, slow outbreaks. The disadvantage is the p-values start to go up. They become less statistically significant. So as I said, it's what we call a robustness analysis. I tried it 7, 15, 30, 60, 90, 180. In the middle, most of the results were the same. This was a little bit better. This was a little bit worse. what was found, what was lost. If it was found, did I want to find it? Did it look true or did it look false? And if I lost it, did I mind losing it? If I lost a true positive, I'm worried. If I lost a false positive, that's a good thing. Yeah, and as I said, this idea of false positives, and there's a difference between, are we finding outbreaks? You need an epidemiological evaluation. There's a simpler question, did I want to be notified? The answer is often yes. I don't know if it's an outbreak, but yes, I wanted to be notified. So this question wasn't an outbreak or not. It's very hard to know for the historical data. I don't know if it's an outbreak. It was 4 years ago. Maybe it was an outbreak. But an easier question as you're validating this is not to ask, was this an outbreak? Because the answer will be, we don't know. But a simpler question is, would you have wanted to be notified? If you saw this in real time, what would you have done? Ignore it, watch and wait, give it another week, give it another 2 weeks, wait for 2 more people? Or look at the chart. What were the diagnoses? Were these hospital infections? What were the resistance patterns? What was the Vitek bio number? What was the biotype in microscan? Or should I start sending an investigation team? Should I do swabbing? Should I look at hygiene measures? Should I start cleaning? So this is, I can talk on this in the next webinar. Now that you have these statistical findings, what do you do with them? Is it an outbreak or not? StatsCan will not tell you. You will say, StatsCan will say, this is statistically unusual. It's up to you to decide if you want to investigate, if you want to respond, and how. Almost all of our papers, except for the one of the Shigella papers, were historical data, retrospective. We are wrapping up and publishing, and we already have posters on a prospective project with 80 US hospitals funded by the CDC. 40 of the hospitals, we are telling them WHONET-SaTScan results every day. The other 40 hospitals, we're running the analyses, but we are not telling them the results. That is our control group. So we're seeing in real time outbreak detection and genome sequencing and responses and further investigations. So this is a very powerful study to really try to help us determine, were these signals meaningful? Were they molecularly confirmed? Did people take action on the signals? And did those actions have any impact? Those are all important. They're different questions, and they are all important questions. 1, did I want to be notified? Yes. 2, was it a real outbreak confirmed by epidemiologic and molecular studies? 3, did people take action? If they don't take action, all of this other work doesn't matter. And 4, did those actions have an impact? So this is the work of our current study that is now finishing about prospective assessment and validation and intervention. Is there a way that StatsCan manages bias occurred to adjusted outbreaks that had occurred unnoticed? So StatsCan has a number of features that we are not currently utilizing. I did show in one of my early slides with the Acinetobacter, there was a big peak of Acinetobacter in certain months. And then a few months later, there was another recurrence. The ability to find the second outbreak will be compromised by the first outbreak because the baseline is much higher because of the outbreak. There is a way to deal with that in StatsCan. You can tell StatsCan, ignore the outbreak period. Don't utilize these dates. One way to do that is basically smooth out that period or just ignore the dates. So there are ways that we have not yet thoroughly evaluated where, yes, you can play around with the StatsCan and the WHONET features to deal with the outbreaks. WHONET we predominantly use to find potential outbreaks. I never did mention the difference between the detailed report and the summary report. The detailed report does allow you to monitor the evolution of the outbreak. We found the outbreak, potential outbreak, on Monday with 3 people, and then Wednesday with 5 people, and then Friday with 10 people. So I kept on mentioning this is the detailed report, this is the summary report. The detailed report helps you to look at the evolution of the outbreak. It started with this statistical significance, more people, more statistically significant, and then a return to baseline, and then it stops generating signals. So in the detailed report, it allows you to see the evolution monitor the evolution for that first outbreak. If there's a second outbreak, if you have a known confirmed outbreak, you basically StatsScan, you cut it out so it's no longer part of the baseline, so that you're not compromising your ability to find further recurrences of that outbreak. I don't see any other questions. Since I have time. Yes, go ahead.
John, there's one up a little bit. It starts for retrospective method start date. Keep going up a little bit. Yes.
Okay, for retrospective start date and end date parameters, what's the difference between default values and specified values from results perspective? In other words, are we going to see cluster alerts anyway if cluster does exist? Okay, so let me go to that. We'll continue out of here and analysis type. And let me just put this back to resistance profile. And let's see. Yes. To make things simple for everybody, we just put first date to last date. That way you don't have to keep track of the time period you are utilizing. One of the reasons I will use this feature is sometimes there are bad dates in the database, especially for people doing manual data entry. They will have a sample from January 1980. It was just a typing mistake. Maybe it was somebody's birthday. Or you'll see a date of 2030 or 2050. So one of the reasons I put an exact date is just to ignore those completely invalid dates. Right, so with the retrospective, it will only focus on this time period, looking for clusters within that range and ignore all the isolates outside of this range will be ignored. Let's see, I did want to show simulated perspective. I'm going to change my threshold. The default threshold is 365. Let me just put that something very small, like 7 days. It's just going to be a once a week occurrence. This is much too small to be meaningful. So you will see a combination of true alerts and basically just random noise. I want to show you, the reason I am doing that is I want to show you the difference between the detailed report and the summary report. And let me just go back and put this on organism. I think that's good. So lower left, let's see. Options. Oh, I have to put the dates. The dates are wrong. First date to last date. In the bottom left, you see it is marching through the database. It's looking for outbreaks every day. And I thought I mean, it worked, but it didn't. I was hoping to see. Oh no, here's the example I was looking for. Cluster number 1. If you look at the left-hand column, cluster number 1, 2, 3, 4, 5, 6, 7, 7. So this cluster generated 2 signals. Let me look at the graph here. So this is the diphtheroid signal that I showed you previously. It was statistically significant with 8 people. Well, it wasn't actually 8 people, it was 7 people. One of those people was there twice. Oops. Oh, Adam, we have a small invalid entry. I'm not sure what's in that. Okay. It's marching through the database again. And the diphtheroids. Okay, excellent. And okay, there it is. It's now numbered 6 and 7. We lost 2 signals because I now removed the repeat isolates. So those repeat isolates was actually the same patient twice. So if you look at the Klebsiella pneumonia, it generated a signal on January 29th. As it marched from left to right, it looked for clusters on January 2nd and 10th and 15th. It looked on January 28th and it did not find anything. It looked on January 29th and it found a cluster with 5 people with a very low recurrence interval of 8. But then when it gets up to the January 30th, this is what's really significant. I put the threshold very low just to highlight this point. Simulated perspective, it found this cluster on the 29th. And that's this graph. and it found it again on the 30th. So this is what I mean by the evolution. It found it Monday with 5 people. It found it Wednesday with 10 people. So you're seeing the distribution over time. So here I see row 6, cluster number 6 appears twice because it was detected twice because the cluster grew. That's the detailed report. When I click on summary, those 2 lines get combined together. So as you can see, if I go to the right, the number of people, it started at 5 people, and then it went up to 10 people. We keep on going to the right. This cluster had 2 signals. Also, this one had 2 signals. I did not notice that one earlier. What organism was this? Streptococcus pneumonia. Let me go back and do the Streptococcus pneumonia. Marching through the database. Streptococcus pneumonia is there twice. It found this cluster 2 people on the same day, on January 16th. And you have to keep in mind what it's comparing it to. It's comparing January 16th to the 1 year of data before it. So on January 16th, it does not see the patients on January 18th or January 26th. January 16th, it's only looking at the previous year of data. And when I compare those 2 people with the previous data, that was statistically significant. And then if I go to January 18th, it generated another signal. Here I can see the signal started with 2 people and then it went up to 4 people. That's the detailed report. This is the summary report where those 2 rows have now been combined together, showing that this was originally detected with 2 people and eventually ended up to be 4 people. And we only expected 0.77 people. Continue, and then this is actually the list of the people if you wanted to see all of the details. And continue. Okay, Adam, any other questions down there?
There's one final question there at the bottom.
Okay, how can we construct a query to cluster alerts based on service plus organism? Do we need additional input files to build department aggregates? So let me go back to WHONET. It depends on your data. For example, WHONET has a field called location, which we use to mean the ward of the clinic. WHONET has another field called department, which we mean to mean the service. The department might be rheumatology, it might be cardiac surgery. So because we have a data field for the service or for the department, we utilize those fields. If you do not have that field, then you can build together a grouping of locations. This will be a subject of the next webinar, but let me go to Notepad. Let me try to go to Notepad. It's very simple. Let me close that. Okay, for example, I'm going to create something called the 5th floor. And that's going to be 5A and 5B and 5C and 5D. Or in my own hospital, we have 4A, I forget, 6A, 6B, 6C, and 4A. Because those are the 4 places where we do bone marrow transplant. So even though the 4A is on a different floor, they share doctors and nurses and equipment and patients that might go between them. So this is not the focus of this webinar, but since you asked, we will discuss this on the future webinar. This is how you can group them together. Alternatively, you can have, like in a hospital network, you can have all of the Boston hospitals, Brigham and Women's Hospital, Mass General Hospital. I can have the suburbs. This would be the, where's my bracket, equals Newton Wellesley Hospital, North Shore Hospital, I forget the name of it, Faulkner Hospital. And then I could say other. And then we have other could be, we have Cape Cod Hospital. We have Nantucket. So it's very easy. So yes, I do have the latitude and longitude of all of these hospitals, but that's very rigid. And as I said, 2 miles in the city of Boston, you already have like 5 hospitals. 2 miles out in Nantucket is on an island. So 2 miles doesn't really mean the same thing. So even if I do have the latitude and longitude, we still find it valuable to group the hospitals in this kind of way, which is more meaningful with regards to patient sharing areas. Another way to do this is by network. For example, my network is MGB, Mass General Brigham, but we overlap with another network called Beth Israel Deaconess Medical Center. So the hospitals are all very close to each other, but we have different patterns for sharing patients. So I'll talk about this more in the next webinar about how we can do these kinds of groupings. Okay, I see, is it correct to assume that the text output reports the detail of the list of analyses? So the more granular detail that Access also provides in aggregate. The output reports the detail of the ICE listing, the more granular detail. Yeah, that's right. I showed you 3 parts. The detailed signals, the summary signals, and then the people who are in those signals. So that's the lowest level of granularity. It has the patient location and the date and the specimen type, the zone diameters, the MIC values. If you have it, the Vitek bio number. One of the publications that I showed you was about using bio numbers. Everything I showed you today was cluster detection using the species name and the resistance pattern. But we do have the one publication where you can also use the bio number. We were going to develop that further, but then people switched over very quickly to MultiTOF. We would love to do something similar for MultiTOF. If anybody would like to pursue this collaboratively, of course, that would be an interest. I'll stop sharing my screen. So on the next presentation, part 2, I can talk about the specific studies that we did. We've had many students do their theses from the London School of Hygiene and Tropical Medicine and some other universities. So I can talk more about the science and the interpretation. The focus of today was the mechanics. Where do you find the options? What do the parameters mean? But I didn't talk so much about optimizing. I talked a little bit about robustness, but in the next time I can dive a little bit more into some of the results of the studies that we did. I mean, I guess I can summarize one of the conclusions of our first paper was that for hospital work, all of the large important outbreaks we found with SaTScan. That's reassuring. The outbreaks that we knew we had, we were able to find with SaTScan. That's one advantage. Second advantage is a more important advantage is we found a lot of clusters that looked like outbreaks that we had no clue. A lot of fungus, a lot of susceptible organisms, a lot of uncommon species. So by taking a statistical approach, we're looking at all organisms, all resistance patterns, all locations, all at the same time. That's the second advantage. The third advantage is that we did a better job of finding MRSA outbreaks and VRE because we look at that very carefully. But we were applying the rule, 3 MRSAs in a 2-week period in a room triggered outbreak alert. The problem is many times those MRSA were not related to each other. They had different resistance patterns. So even for organisms that we studied very carefully, the statistical approach found much better. We had much better sensitivity and precision because we were not grouping together MRSA that were unrelated as suggested by their phenotype. When is part 2? Right now I'm thinking part 2 might be at the end of February. I'd love to do the antibiograms, but the CLSI breakpoints have not been published yet. There's some work we want to do with the UCAST. I is no longer intermediate. I is now susceptible with increased exposure. Traditionally, antibiograms are done with percent susceptible. But for people using UCAST, it actually makes more sense to do the antibiogram with the percent I plus the percent S. So we'd like to do some more programming to make some of these features more obvious. Right now, WHONET has that feature, but it's called percent non-resistant. And percent non-resistant is not very obvious that it's the I susceptible plus the S susceptible. So I don't think February we will be ready programming-wise to do the antibiogram lecture. So I'm thinking the end of February will probably be the part 2. Okay. Why does a cluster activate before generating the first signal? I have a cluster whose bars turn red at the maximum date of the first signal generated. So WHONET is looking every day. Do we have an outbreak today? Do we have an outbreak today? And if WHONET says we have an outbreak today, WHONET generates a signal on that day. But the outbreak might have started a few days before. Or a week or 2 weeks before. So there's a difference between the notification date, the alert date, and when StatScan thinks the cluster started. So for example, there might be 2 people on Friday, and that itself is not interesting. But if the 2 people followed 3 people and followed 2 people, the alert date is Friday, but the cluster is going to be a few days or a few weeks before that. Hi, Valeria from Ecuador. Saludos. We were wondering if you could talk a bit about WHONET for other surveillances apart from the hospital settings. We do have a couple of papers on Salmonella and Shigella, but I think it's almost half an hour past. So I think I will leave that for a discussion in the next part 2. The work we have done has been that Salmonella Shigella, but the work could be applied to COVID or to anything with a laboratory test result, C. difficile inside the hospital setting. So as you saw, StatScan doesn't care. StatScan, these are just simply numbers. Cases of schizophrenia, cases of thyroid cancer. So yes, obviously, we can look in the community setting, but we have not done a lot of work of that nature. I guess for one main reason is that is the job of the health department, is community health. And a lot of our people are hospital infection control team. So for the hospital infection control team, the outbreaks are the hospital's faults and the hospital's responsibility. Whereas the community outbreaks is not the fault of the health department, but it is their job to respond. So it's a different set of audiences, and but we'd love to work with national programs to help them look for both hospital and community outbreaks. I guess another challenge with community outbreaks is a lot of times we don't have a lot of laboratory confirmations. So you might have a very large outbreak of salmonellosis, but very few people have a lab sample, so that's an obstacle. We had one student who looked at outbreak detection in Argentina. He focused on hospital outbreak detection in the way that I showed you here. He also focused on detection of pertussis outbreaks and I think norovirus in the community without using laboratory data. He was using clinical diagnoses because WHONET doesn't really care and StatScan doesn't really care. So I can talk about that next time as well, the use of StatScan, because for his work, he had weekly totals. How many cases of pertussis did we have in each clinic in different parts of the country? WHONET cannot deal with aggregate data, so he did not do that portion of his work with WHONET. He used StatScan himself manually, because StatScan can handle daily or weekly or monthly data. So I can provide more background on that in the part 2 of this webinar.